Welcome to Raise the Line with Osmosis from Elsevier, seeking solutions with leading experts on how to increase healthcare capacity so people can get the care they need during the pandemic and beyond.
Hi, I'm Shiv Gaglani. Today we are happy to share another remarkable story of a rare disease parent and the contributions they've made beyond their efforts to help their own loved ones. Our guest is Nick Sireau, who's the CEO and Chair of Trustees at the AKU Society, an award-winning patient group that helps people with Alkaptonuria, or AKU, which is a rare genetic disease affecting both of his children. Nick is also the co-founder and chair of Beacon, an organization that helps all rare disease patient groups, and plays the same roles at Orchard OCD, a medical charity that funds research into obsessive-compulsive disorder. Perhaps most impressive of all, he's involved in making the very first treatment of AKU available. Before we get started, I'd like to thank Philippe Pachter, who is a podcast guest, for highly recommending and connecting me to Nick, as well as a friend at former Elsevier colleague, Tim Hochter, who I learned over several conversations. Tim hearing Nick speak at a conference was why Elsevier, in large part, why Elsevier got involved in the rare disease space in the first place. So Nick, it's an honor to have you with us today.
Thank you very much. Good to speak to you.
So in your own words, we'd love our audience to learn about your background. What got you interested in the world of rare diseases? Was this something interesting before your children or, obviously after your children? Just give us the background.
Yeah, absolutely. So I really started developing an interest in rare diseases after the birth of my first son, Julian, in late 2000. And when we brought him back from the maternity clinic on a Sunday, we noticed that his nappies were going red-black. And so we called an emergency doctor who tested for blood and didn't find any, and who asked what we'd eaten. And we'd had some red cabbage that day. So he said it was the dye from the red cabbage entering the breast milk and then the baby and going to the urine. And we were not very impressed by this answer, to be perfectly honest. So the next day we went to see our GP, who did a whole bunch of tests. He sent off for some tests at Great Ormond Street Hospital in London. And it came back with this diagnosis of this ultra rare disease called Alkaptonuria, which we call AKU, or which we now call black bone disease. So up until then, I wasn't aware of rare diseases at all. Had no idea that there were thousands of these rare diseases, no idea that these diseases affect millions of people, and really no idea about Alkaptonuria, which affects one person in roughly 500,000. So our GP said, whatever you do, don't go on the internet. And obviously that's exactly what we did. So this was in late 2000. We came across loads of really pretty horrible stories of people suffering from this AKU, this black bone disease, becoming severely disabled as life progressed. So we were very alarmed. And I got in touch with a patient in Liverpool called Robert Gregory, who had just made contact with a doctor called Dr. Ranganath at the Royal Liverpool University Hospital. And Robert had convinced Ranga, as we call him, to set up a patient group with him. And so he invited me to join. And that's really when things started. So by then, my second son had been born. He was also diagnosed with Alkaptonuria. And in 2003, we set up the AKU Society, which was the world's first patient group helping patients with this disease.
That's incredible. Obviously took fast action and luckily got that diagnosis pretty quickly and didn't listen to that first GP about avoid red cabbage because one thing we've learned about the rare disease space is it takes an average rare disease patient 4 to 9 years to get a diagnosis. And so that is valuable time where they could be getting some therapy or a parent like you could jump into action and help develop a treatment. So give us a bit more of a sense of AKU, kind of how it affects patients. You already mentioned how rare it is. What are the palliative as well as the treatments that you're working on?
Yeah, absolutely. So the first symptom is the urine going red-black, and that is due to a certain acid called homogentisic acid, which we call HGA, which accumulates in the body at 2,000 times the normal rate. Now, it's a single gene defect, so it's a monogenic disease. And basically, because of that gene defect, because of the mutation, they have a certain enzyme called the homogentisate dioxygenase enzyme, HGD enzyme, which malfunctions or doesn't properly form. And because of that, they can't break down this homogentisic acid. So us who don't have AKU, we can break it down. With AKU, they can't break it down. And that acid accumulates and it binds to cartilage and bone over time. And it goes black. in a process called ochronosis. And that's why it's called black bone disease. So this takes time. It takes years, sometimes decades. So generally in childhood, all you see is the urine, the sweat tends to go black, the earwax and all that. But the real clinical symptoms, the painful symptoms, will tend to start in early adulthood. And that will be problems with the spine and then the weight-bearing joints. So the spine will start to collapse and fuse. All the weight-bearing joints will start to fall apart because the cartilage and bone starts to fragment. Bob Gregory, founder of the AKU Society, said it felt like having barbed wire in his joints, and then also the heart valves will start to calcify, and people will have problems with their eyes and their ears and different parts of the body. So it's a multisystemic disease, as are most rare genetic diseases. And we have one patient, for instance, who has had 12 joint replacements. He's had every major joint in the body replaced. So and each time you go for a joint placement, it's a pretty significant operation. And then it does also affect lifespan. We see people dying earlier because of problems with the heart and all that. So it's a pretty nasty disease, particularly painful. And of course, there's all kinds of ramifications for mental health. Many of our patients suffer from depression, anxiety. They will tend to lose their jobs because they can't work. Often their relationships will break down and all that. We had one patient who was sleeping on a park bench for ages and all that till he got support from social services. So it's a pretty nasty disease. Now, it's actually pretty well known amongst clinicians because it was the first disease to be shown to be inherited. So there is a professor in London in 1901 called Sir Archibald Garrod, who managed to show that AKU was inherited. And that was the first time anybody had shown that a disease could be inherited. Until then, people knew disease could be contagious, but no one knew they could be inherited. And so he called it an inborn error of metabolism. And there's now hundreds, if not thousands, of these inborn error of metabolisms. So doctors will often remember that from, very vaguely from just reading about it in their kind of clinical history books and stuff, But that doesn't necessarily make diagnosis any easier. So you're absolutely right. If our patients are not diagnosed at birth, so sometimes the doctors will come with all kinds of reasons like red cabbage or whatever. So then the patients will go on for the rest of, for years before the pain actually gets them back to see a doctor. And sometimes it can take 10, 20 or 30 years. We had one patient, it took 40 years before he had a diagnosis, and they are sent from misdiagnosis to misdiagnosis, sent for psychiatric treatment because doctors don't believe them. It's pretty nasty, the whole diagnostic odyssey. So what we've been doing when we set up the AKU Society is we did a lot of basic research into AKU. Even though people knew about it for more than 100 years, our scientific understanding was pretty rudimentary. So as a patient group, I did lots of fundraising. We paid for a mouse model of the disease to be developed, which was very successful, a natural history study, a cell model, a post-mortem of a patient. And then there was a trial of a particular drug called nitisinone in the States at the NIH, which unfortunately failed in 2009, even though it was reducing the acid by 95%. And patients on the trial were raving about it. But it failed basically because of a problem with the trial design. It didn't last long enough, wasn't enough patients. The endpoint wasn't really sophisticated enough. So with the Liverpool group that we had put together with Professor Ranganath, Ranga basically developed a whole kind of clinical development program for nitisinone. And what we did then, 10 years ago, we applied for funding to the European Commission. We got 6 million euros in funding. We put together a European consortium. We managed to convince the company that owned the drug, Swedish Orphan Biovitrum, to join us. And then we did a phase 2 clinical trial and a phase 3 clinical trial, both of which were successful. They showed not only a reduction of 99.8% in the acid, but they also showed a statistical benefit in clinical symptoms. And so the SOBI, Swedish Orphan, applied to the European Medicines Agency 2 years ago, and they gave a positive opinion, and then the European Commission gave a marketing authorization. So now all AKU patients in Europe and the UK can have access to this drug nitisinone. So it's an absolute lifesaver. And both my boys are on the drug. I'm just back from Liverpool today with my son Daniel, where we went for his week-long annual checkup for his AKU, so MRIs, X-rays, everything you can imagine, and also, to renew his prescription for nitisinone. So overall, it's gone really well. We're really happy.
That's incredible. What a great story. And before we go deeper into that and the pharma industry and thoughts on creating more rare disease drugs, what you mentioned Daniel and you just got back from Liverpool, good checkup. How old are your kids now? How are they doing? Just can you give us any more background on them at this point?
Sure. So they are aged 21 and 19. Our eldest has now been on nitazoxanone for 4 years. His dosage has just been increased, actually, and that's going really well. And Daniel, who's 19, has been on the drug now for 2 years. They don't have any of the clinical symptoms, because hopefully the drug will have been started in time. And the benefit, however, of going to this national centre that was set up 10 years ago by Professor Ranganath in Liverpool is that it's a one-stop shop. So what you need, particularly for ultra-rare diseases, is a real centre of excellence, in each country. Where you have a multidisciplinary team, you have clinicians and rheumatologists and metabolic consultants and orthopedic surgeons and everything who really understand the disease. Because until you have that, patients are sent from pillar to post. They go and see one doctor in one hospital, another doctor in another. There's no coordination. The doctors might have just seen one patient before in their whole career. It's just all over the place. And that's why this national centre was set up 10 years ago. So when the patients go there, when my boys go there, they have access to world leading experts in AKU, which means that there's a better understanding of the disease, there's better monitoring. They can detect early signs of possible problems and all that. And also they can then prescribe the drug, so far things are going really well.
That's awesome. And these centers for excellence, Philippe mentioned as well, like for his daughter, Liziane, who was born in the normal French maternity ward, did not get the best care immediately for Pierre-Robin sequence, ideally would have gone to the center in Germany. And then in that case, we have to make cross-border care, which is a topic I know he's been working very hard on, more accessible. So we're coming up on the 40th anniversary in the US of the Orphan Drug Act, which obviously has really helped pharma companies incentivize them to spend time developing treatments for rare disorders like the one for AKU. I'm curious, what more can the pharma industry do to help for the other 7,000 or so zebras that exist?
Yeah, I think there's a lot, actually. And one of the problems is there's pretty big market failure, I think, in rare diseases, and for that, obviously, pharma companies are profit-making businesses, but they will tend to avoid, obviously, those diseases where they can't make a return on investment. They have investors who want to make their money back and all that kind of stuff. So, there's hundreds, if not thousands, of these ultra-rare diseases that just nobody is touching. Because they're not managing to potentially get their investment back and all that. So I think there's a lot of things actually that pharma could do. I think they could look at alternative business models. For instance, the one that we developed was a public-private partnership. So we got public funding from the European Commission. But the pharma company Sobi also put in some of their own money. They put in 3 million euros, compared to the EC 6 million. So it was a public-private partnership. And they will make some money back from sales of the drug and all that. But now that the drug is off patent in their generics, it's obviously not going to be a blockbuster, So one of the things I've been trying to tell pharma companies is that, yes, it's good for them to aim for their blockbuster drugs or their drugs that will generate significant revenue, but they should also maybe have one or two drugs in their portfolio where they're looking at, maybe breaking even or some kind of low profits or whatever, as a more kind of philanthropic approach. That'd be the first thing. I think the second thing is the pharma industry could look at what the legal industry does. So all the big legal firms have pro bono departments, which are funded by their profits and where they treat charities as full clients, but they don't charge them. And I think the pharma industry could do that too. There is one company in Cambridge in the UK where I am called Costello Medical. They're an absolutely fantastic company. They do health economics and they have a pro bono department. And they have done a lot of work for us on AKU, for instance, on the AKU Severity Score Index, which is one of the endpoints that we had for the trials, where they've given us, I think, at least 80,000 or 100,000 pounds worth of pro bono support, and they treat us like real clients. So I think if the pharma industry set up these pro bono departments, they could help rare disease patient groups by providing them pro bono support on clinical development plans, on all these kinds of things that we need help for. I think that's the second thing. And the third thing I think should happen is I think that the pharma industry should be donating much more to patient groups. I mean, as patient groups, we're always struggling for funds. Most of our funds come from friends and family. If we run marathons, half marathons, coffee mornings, all that. Trusts and foundations in the UK from the big lottery fund, some government funding from the NHS or from the European Commission. Very little comes from the pharma industry. And the reason for that is the pharma industry gives very little money to patient groups, for all kinds of reasons, which I don't really believe in. But we also have to jump through so many hoops. I'll give an example. We applied to a pharma company a number of years ago for like £10,000 to do our patient workshop. It took 6 months, loads of forms. In the end, we got £300. It was just like, it just was not worth the effort. And the administrative burden they put on patient groups is absolutely huge. So what I believe they should do is they should put a small percentage of their profit into an independent foundation, which would then provide support to patient groups. And I think the best example for that is to see what the Chan Zuckerberg Initiative has done in the US. So they were set up by the Facebook founder, Mark Zuckerberg, and his wife, Priscilla Chan. They've put 99% of their shares into the Chan Zuckerberg Initiative, who do all kinds of things. But one of the things they do is they support rare disease patient groups. And every couple of years, they do a call for proposals where they support 20 or 30 patient groups, and they give each patient group $600,000. Now, with that money, you can recruit a couple of members of staff, you can do a scientific development plan, you can develop a registry, you can start really interacting with industry. That's what I believe pharma should be doing.
That's really interesting, and like all those very actionable suggestions, I think are key. And hopefully, just like we can't say all rare diseases are equal or all pharma companies are equal. There's certainly some pharma companies that are probably more ahead of the game than others in terms of thinking in this way.
That's absolutely right. And the prime example is the company we work with, Sobi, who I think were well ahead of the game. And I have nothing but praise really for what they've done.
Yeah, that's awesome. That's great. One point we like to make to our learners, because many of them are current and future healthcare professionals, why they should care about the zebras too, apart from clearly having stories like yours and John Crowley and David Feigenbaum, we've had people like them on the podcast too, where it's very motivating. You hear the passion, the voice, and you get a lot of gratitude from these patients and patient groups if you dedicate your research career or provider career to these groups. Is that the actual science underpinning some of why these disorders exist, by elucidating that there could be applications well beyond that rare disease or that collection of rare diseases. The case we like to always share is, actually the development of Castleman disease drugs, David Feigenbaum was telling me, led to a drug that has saved tens of thousands or hundreds of thousands of lives from COVID. Or familial hypercholesterolemia led to the development of statins. What I'm kind of maybe taking the wind out of the sails here, but I'm curious, given all that you've done across many disease states, including AKU, what can rare diseases teach us about common diseases and human biology?
Yeah, I mean, that's a key point. And people have been saying that for hundreds of years. I mean, the founder of modern medicine, I think in the 16th century, said that understanding rare diseases helps us understand human biology. And Sir Archibald Garrod, who discovered AKU as an inherited disease, said exactly the same. And so did William Bateson, who was his contemporary, the father of modern genetics, and so did Francis Collins, head of the NIH, and all that. So people have known that for a while. So a few things there, particular to AKU. I mean, you gave some very good examples there, but AKU is an extreme form of osteoarthritis. Okay, and our studies in Liverpool of AKU have led to new discoveries in the kind of the molecular kind of disease of osteoarthritis, which we published about a few years ago. So it helps us understand the more wider diseases. And one of the reasons why, I think, is because rare diseases are often actually quite simple biologically, so they help us understand these biological mechanisms. But the second one, which is really exciting, we had a presentation. We did a scientific workshop in Brussels in May, and we had a scientific presentation from a group, Alvaro, from the Liverpool School of Tropical Medicine, on this drug nitisinone. So the drug nitisinone, which we use for AKU, was originally developed as a weed killer. It was developed as a weed killer in the 80s. And it works as a weed killer because it kills photosynthesis. It stops photosynthesis. And it works in the tyrosine metabolic pathway in plants. Okay. It was never commercialized as a weed killer because it was too potent. But an analog of nitisinone called mesotrione is one of the world's most successful weed killers, and you can buy it from any garden center. Anyway, nitisinone, they then thought, well, if it works on the tyrosine pathway in plants, it should work on that pathway in humans. So they then developed it for a rare disease called tyrosinemia type 1, which kills children by age 2, and which is on the same pathway as AKU. And that was in the early 90s. And then they thought, well, let's use it for AKU. Okay, so it was repurposed for that. But more recently, in the past 2 or 3 years, this team at the Liverpool School of Tropical Medicine, working with our Professor Ranganath, is developing nitisinone as a way of controlling mosquitoes in developing countries. Because when mosquitoes take blood from someone who has taken nitisinone, the mosquitoes die. And I don't understand the exact mechanism. They explained it to us and all that. And, you know, it's I think, available online. And there's an article in Beacon on their website, on the Beacon website, all about it. But something to do with the increase in tyrosine that happens when you take nitisinone kills the mosquito. So what they are now trying to do is develop it as a medication that would be taken all across, say, sub-Saharan Africa as a way of controlling the mosquito population. So what you'd end up with is a drug originally developed as a weed killer, then developed for 2 rare diseases, potentially now helping in the fight against malaria and dengue fever and all those kinds of things, you know. So it's still a way away, but I think, you know, it's just incredible, actually, what can happen when you start studying rare genetic diseases. And when we give the blood of AKU patients who've taken nitisinone to mosquitoes in the Liverpool School of Tropical Diseases, all the mosquitoes die, basically. First of all, they start to fly all over the place and they get paralyzed and then they die, you know. So there really is something there that I think is worth exploring further.
That's amazing. And you know, I mentioned we had one of our guests that we had on the podcast is David Feigenbaum, who I'm sure you know well, wrote the book Chasing My Cure. And this week, he and I will both be at the Clinton Global Initiative for different reasons, rare disease related, but he'll be launching a drug repurposing initiative for that exact reason, that there's 3,000 plus humans have created 3,000 plus drugs or discovered. You know, obviously we didn't create all these drugs. Some of them are just natural, but we only have a very limited understanding of how many of them can be applied. So that's a wonderful example. A weed killer turned something that's saving yours and many of people with AKU's lives, and now potentially a malaria treatment or population control. I'm curious, you know, obviously why you got involved with AKU is clear. How did the OCD connection come into play, and what are you doing with Orchard?
Yeah. So I have had obsessive compulsive disorder, OCD, for just over 30 years, on and off, sometimes really, really badly, particularly 6-7 years ago with an episode of incredibly severe depression, which meant that I had to leave my job and, you know, all kinds of problems and all that. And what happened was, for a while, I've been thinking that, so I don't know how much your listeners, viewers know about OCD. It's a very common disease, you know, so it affects about 2 to 3% of the population, maybe even more. So in the UK, that's about 1 million to 1.5 million. It is very trivialized by the media, by society, and even by the medical profession. You know, the whole expression "I'm a little bit OCD" really creates problems, because the public perceptions of OCD is that it's just a quirk of personality. In reality, it's a devastating disorder. 50% of patients have it very severely. One of my best friends took his own life 2.5 years ago because his OCD got so out of hand, and I run an OCD support group here in Cambridge. We have patients who haven't left their house for 10, 15 years. 1 in 10 patients with OCD will attempt suicide. You know, 60% are depressed. It's just awful. And a lot of OCD is actually not the traditional types that people are aware of. So people are aware of contamination OCD, they're aware of checking OCD, but there's a whole aspect of OCD which we call pure OCD, which is really all in the mind, where your obsessions and rituals are entirely in the mind. And they tend to be linked to fears of doing harm, blasphemous thoughts, all kinds of things. I'll give an example. One of my friends has a form of OCD called false memory OCD. Or at least that's what he calls it and what other patients call it, where basically his mind will construct false memories of horrible things that he's never done. But the memories will seem so real that he will spend 24 hours a day, because he doesn't sleep much and all that, obsessing about these false memories, asking themselves, could they be true? Could they not be true? And all that. And then creating all kinds of mental rituals, neutralizing thoughts to try and make it better and all that. And so, and obviously that leads to suicidal thoughts. It's just absolutely horrific. Another form of OCD is what they call postnatal OCD. Just like you get postnatal depression, these will be new mums. They will just get an intrusive thought. What if I suddenly threw my baby out the window? And they'll be just like, what a horrible thought to have. I must be an absolutely awful, horrible person. I'd better never have that thought again. And so they're checking if they have that thought. And obviously, if you check if you're going to have a thought, you have it. It's the pink elephant thing. And they're like, I've had that thought again. I must be a really, really horrible person, and then they start obsessing about it and trying to think positive thoughts. And then they don't dare touch their baby. And it just all escalates and it just gets totally out of hand and, just awful. So I was finding that treatments were pretty poor. It tends to be high doses of antidepressants, sertraline, Prozac, etc., with all kinds of side effects. They take months to have an effect, or cognitive behavioral therapy, which also doesn't always work and which is very hard to access. In Cambridge, we have an 18-month waiting list to access cognitive behavioral therapy. So when I got very bad 6 years ago, my older brother told me, look, if you set up a foundation to fund research into treatments, I'll support you and help you get this off the ground. So that's what he did. So Orchard OCD, basically, we're entirely non-profit and we fund non-commercial projects that will help develop treatments. So we have two projects that we've really worked on. The first is a medical device called transcranial direct current stimulation, which is a small medical device where you put two electrodes on your scalp and it puts a very faint, nearly imperceptible electric current. And we did that with Professor Naomi Feinberg at the University of Hertfordshire. And it was a feasibility study and it detected a signal, as in patients saw a noticeable reduction in their obsessions, in their OCD. And so now we're raising funds to do a much larger trial to really test that, And then the second study, which starts any day, is testing a psychedelic. So you're probably aware that psychedelics are the new frontier in neuroscience. People have known about it for decades, but because of the completely stupid drug laws that we have, which have made them all completely illegal, it's only recently that research has started. It's just criminal what these drug laws have prevented people from doing. But anyway, we are funding Professor David Nutt, who's a big name in this area at Imperial College. And we did a crowdfunding campaign for that. And the study starts any day. It'll be an 18-month study on 20 patients where they will be given 10 milligrams of psilocybin, which is the active ingredient in magic mushrooms. So not enough to have a full-blown psychedelic trip, but hopefully enough to help with what we call cognitive inflexibility, which is the kind of rigidness in thinking, which seems to be at the core of OCD, So yeah, that's why I'm involved in that. We just did another call for proposals. We should hear in the coming weeks who's the winner for that, and we'll be funding them. So the idea is to develop new treatments for a very misunderstood and very under-researched mental disorder.
That's very exciting. And one of our previous guests on the podcast was Jim Fadiman, who's the father of microdosing on psychedelics. And my board member, Mitch Rothschild, his wife, Rachel Yehuda, runs the Mount Sinai and Veterans Affairs MAPS trials for PTSD using MDMA-assisted psychotherapy. So it's a very exciting time. It'll be very interesting to see which one of those, or hopefully both of them, have an impact on OCD at various endpoints. And you've done it before for AKU. I'm positive there'll be some good outcomes for OCD as well.
Thank you.
I know we're coming up in time, and I want to be respectful of yours. Two last questions. Sure. Osmosis is a teaching company at its heart. If you could snap your fingers and teach any group of people, the public, health professionals, researchers, anyone, about something, what would it be and why?
Well, the first thing for rare diseases would be to help people understand that these rare diseases are common. When we did a survey a few years ago on students about rare diseases, we asked them, how many rare diseases do you think exist? How many people and all that? The answer was generally, we reckon there might be 5 rare diseases affecting a few hundred people in the UK. And then it's like, actually, there's 7,000 rare diseases affecting millions of people, So I think that's the first thing. People need to understand that rare is common. That's the key thing. And then on OCD, I think for people to understand that OCD is a devastating disorder, and to really help people to stop using this language, which devalues OCD, because it might seem like just a few words, but it has an impact. It has an impact on clinicians who don't take OCD seriously. It has an impact on funders who don't take OCD seriously and hence often don't want to fund OCD. And it has an impact on the pharma industry. I was speaking to some pharmaceutical investors the other day, and they were like, why would we want to invest in OCD? You know, it's not a particularly nasty disorder. And I was like, it is. It's horrific. And at its worst, it's as bad as full-blown schizophrenia. So those are the two things I'd really want to focus on.
That's really, really helpful. We'll do our part on at least the first one, and we're already starting to.
Yeah.
The second one we can further explore. And then last question, what advice would you give to our audience about approaching their career in healthcare?
Well, gosh, that is a really interesting one. I'd say to keep a really open mind, when you approach your studies and all that. To look at what is not always the most obvious. I'd say that's the first thing. So the clinicians and scientists and all that I've been really most in admiration of is those who have a very open mind and who will go down areas that other people won't. I say that would be the first thing. Secondly, to really go to those areas that are under-researched and where there's a real underdog, which you get a lot in rare diseases. It's from a career perspective, it's not going to be amazing really for your career to particularly study a rare disease, but the impact that you can have on a population which is more or less abandoned by society and by, the medical industry and everything, I think is absolutely crucial. And the third thing is to really be motivated. My hero is Professor Ranganath, who I've now known for 20 years. Without him, none of what we've accomplished could have been done. The NHS in the UK is a pretty difficult environment, I think, to work in. I think it's getting more difficult for all kinds of reasons. And yet people like Professor Ranganath are the real heroes who are driving things forward, who has 100% commitment to the patients, but also a real curiosity in the science. And I think that's what makes a huge difference. And I always say when I speak to new rare disease patient groups, if you can, try and find your Professor Ranganath, because that's what will make a difference, And I think he's the kind of example for new scientists and new clinicians who are entering the field.
That's amazing. And I think I would argue too that even though it's, as you said, rare is common, like if you dedicate your career, let's just say a summer, a year, a fellowship, or your career to a rare disease as a current or future healthcare professional, as you said, the patient groups are so happy and so grateful for that person taking their time. But it could also be career game changing because, as we said, if you discover something or treat a new protocol or clinical trial or repurpose a drug, it could have a massive impact well beyond, right? Like, would these malaria trials be potentially happening without the AKU Society, digging that up and then happening to be at Liverpool? Maybe not, and maybe now that could.
I don't know, but what I do know is our AKU team in Liverpool is really collaborating with the guys at the Liverpool School for Tropical Diseases. So there's some real synergies there. Yeah, absolutely.
Well, Nick, this has been a total pleasure. Thank you so much for taking the time to be on the podcast, and more importantly, for the work that you're doing, not just for AKU and your family, but for OCD and rare disease in general.
Excellent. Thanks for your time. Good to speak to you.
And with that, I'm Shiv Gaglani. Thank you to our audience for checking out today's show. And remember to do your part to raise the line and strengthen our healthcare system. We're all in this together. Take care.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelines podcast.